Association, Urologic Association, and the American Urologic Association. Thanks for Dr. Dunstead and Mrs. Laurie. This is welcome, Dr. Kaplan, for your participation in this webinar. We are very happy to collaborate with you for this webinar, BPH and the new technology. Thanks a second time for choose the title. It's very interesting for us. Thanks to the moderator, Professor Belahneche, Dr. ZIOUZIOU, and Dr. KHDACH. Thanks to AstraZeneca for participation and Mrs. Sadrati Yasmin. Finally, thanks Aziz. Pour tous les participants, avant de commencer, vous pouvez poser vos questions en français. Dr. ZIOUZIOU, it's your turn.
Okay,
thank you.
Thank you, Mr. the President, and welcome to all the participants in this new webinar on new techniques of BPH treatment, an evolving topic for a highly frequent disease. As you know, TURP was the treatment of choice of BPH for prostates less than 80 grams, and open prostatectomy was for prostate more than 80 grams. But now, novel techniques offer more possibilities which may minimize side effects and improve sexual dysfunction. So, however, we have some questions questions on long-term results, learning curves, and also on the cost effectiveness. So I would like to introduce today's presenter from New York, Professor Stephen Kaplan, who is a professor of urology at Icahn School of Medicine and at Mount Sinai in New York. He's also the director of benign urologic diseases and the Men's Health Program, and he's also a chair-elect of research at the American Urological Association. Professor Kaplan has a great clinical and research experience as he conducted many trials like PLAS trial, which evaluated the combination therapy of mirabegron with tamsulosin, and also Prospect trial, which assessed the Aqua Ablation. He had also many contributions in many books. The latter was the 12th edition of the Campbell's Urology, and he is the author of more than 1,200 articles. Professor Kaplan is member of editorial boards of many prestigious journals, for example, Urology and Journal of Endourology. He shared his knowledge and experience with urologists from all over the world, as he delivered a lot of courses and master classes. This session will be also moderated by Professor Belahneche, who is a urologist surgeon in Rabat, and also Dr. Younes in Rabat, resident of urology. I would like to remember the audience that you can enjoy this webinar and write down all your questions at the section questions and answers in Zoom, and also you can use the WhatsApp either in English or in French, and also a recorded version of this webinar will be available soon on YouTube. Well, I would like to welcome again Professor Kaplan for being with us. Please, Professor Kaplan, you can start your presentation.
Thank you very much for the kind introduction. And we've had let me just get this good. I think it's all good now. So we had a wonderful time, my wife and I, when we were in Morocco last year. It's a beautiful country. You have a very interesting country, very historic country. It was a pleasure to be there. And therefore, it's a great pleasure to be speaking to all of you and sharing our knowledge. I would much prefer to be in Morocco to give this talk, but I'm in New York, and New York is surviving. You can perhaps maybe see over my shoulder all of Manhattan. Sometimes you don't get to see all of that. There's New Jersey and the river. So New York is still surviving. We've been through a very difficult time, but all is good. So I figured I would show you that as well. But now let's talk about BPH. And to give a good talk on BPH, it would take me about 3 or 4 hours. But we have 30 minutes, so I'm going to try to just give you a summary. So in general, minimally invasive options, and I'm not sure what you have in Morocco. I know some of the technologies. So some of them you may have, some of them you may not have, but at least you'll be able to see some of these things. Minimally invasive options, you want it to be office-based or as an outpatient facility, minimal anesthetic. We originally thought for high-risk patients, but now in the United States, we're using them for really all patients, and as well as low morbidity. And for prostatectomy, which I won't talk too much about, I'll talk about Aqua Ablation a little bit. It's an improved versions that are actually out there. The surgical approaches are based on the concept of removing tissue. We all know that, and this is what you've all done throughout your careers. There are now thermotherapies, the Resume, there is some hybrid therapies, and there's surgical debulking procedures as well. Now, in the United States, about 12 million men are treated for BPH and lower urinary tract symptoms. The vast majority either have medical therapy or WA, which is watchful waiting. Only about 3% are having procedures. The question is, does that make sense? Does it really make sense in today's world to be using long-term medical therapy when we now have these minimally invasive options? And these are questions we are asking ourselves in the United States as well. And the key thing is that a lot of people go off medication. So yes, we'll feel good and we'll write a prescription, but our patients are actually going to wind up staying that. And about a third just stop medicines altogether. So given the fact that in a long-term methodology, a lot of patients don't stay on medication, is that really a good idea? And also sexual function is becoming a bigger deal and a bigger issue. And whether it's in Morocco or the United States or throughout the world, men in their 50s and 60s certainly want to maintain sexual activity and ejaculation. And we now have methods to preserve issues like ejaculation. And why shouldn't we take advantage of that? So one of the issues for us is when to initiate therapy. For example, you have tomorrow a 57-year-old man comes in to your office with symptoms, and that person may live 20 or 30 years life expectancy. Does it make sense to prescribe something for 20 or 30 years for a quality of life disorder? And in addition, changes are occurring in the bladder. The bladder is becoming thicker. The bladder is becoming less compliant. And that becomes an issue in terms of when to intervene with certain types of therapy. So this is the treatment algorithm for male urinary tract symptoms. This is the EAU guidelines. The AUA guidelines is very simple, similar, and I'm just showing you the various types of approaches that can actually occur. So for the most part, there are BPH drugs like alpha blockers and 5-ARIs. PD-5 inhibitors, I think, actually work more in the bladder, but antimuscarinics and beta-3 agonists are the most common agents that we use for the bladder. And each of them have their own side effects. Again, I'm going to focus more on surgical therapy. Now, we also know that despite medical therapy, you can have BPH progression. And this comes from the classic MTOPS trial, which I was privileged to be one of the investigators. And you can see that even on medication, although it's reduced from placebo, there is progression of disease. And in fact, even with monotherapy, there is progression disease, although less than what we see placebo. Now, it's also interesting if you look at the actual improvement in symptoms. So for an alpha blocker like doxazosin, it was only 2 points better than placebo. Finasteride was 1 point better than placebo. Combination therapy was 3 points better than placebo. In the COMBAT study, which did not have a placebo trial, it's pretty similar. About 3 to 4 points for an alpha blocker, about, if you look at this as a placebo, about 1 point, and about 2 or 3 points better for combination therapy. So it's pretty consistent. The question then is that enough to keep somebody on it for so many years? We do know the side effects of alpha blockers. Patients have experienced these. 5-alpha reductase inhibitors have side effects. We also now know of long-term problems, issues like depression and increased risk of dementia. There's actually been data now with alpha blockers as well. So as our population gets older and older, is this something that we really want to continue to use long term? Now, we also talk about the high rates of discontinuation. So in this study from 2003, the average discontinuation rate was 30%, 33% for alpha blockers, 27% for 5-ARIs, and 30% for combination therapy. So we're giving a therapy that may not actually last. In a more recent study, the Sindolo study, about 71% had a discontinuation rate at 6 months. Now, I'm not sure what the environment is in Morocco, whether that would be different, but I suspect men in Morocco are probably no more or less compliant than men in the United States, which means that ultimately, while we may give a prescription initially, the question is, are they going to continue that? And as I alluded to before, are we just putting a Band-Aid on, or are we actually curing patients? And the concern is that you may get continuation and progression of bladder changes. And then if we intervene, will it be too late? And these are questions we constantly ask ourselves to determine whether or not that's really true. So what are the factors driving minimally invasive therapies? Well, one is it's easier. It's in the office. You don't have to go to the hospital. You don't have to have anesthesiologists. You can do it yourself. And theoretically, may not need a catheter. There's less sexual dysfunction, issues like ejaculation, as I'll talk to in a few moments. It's durable. In those patients who have responded, there's now 5 and now 6-year data with the Urolift and the Resume. And the issue for us is always to remember is what evaluations do you need? It's very important to remember that. So obviously you need to do a good history and exam. And for various surgical therapies and minimally invasive therapies, this is very, very important. Prostate size. And I would argue that it's not just the size of the prostate, it's the shape of the prostate. And we recommend this as part of the evaluation prior to initiating a minimally invasive therapy or surgery, because the size of the prostate will help determine, number one, which therapy to use, and number two, whether we expect that therapy to actually work. So it's the prostate size and the shape. And one of the things we look at is something called intravesical protrusion, which is like an intravesical lobe or a ball valving middle lobe. And you've all experienced this, where the lobe goes back and forth. So this is a nice, I think, summary of where we can use different types of therapies, depending on prostate size. For the most part, less than 30 grams, I'm not sure is really BPH, frankly, and whether we need to treat that, and an incision would be fine. From 30 to about 100 grams, I think you can use virtually everything. More specifically, the Urolift and Resume is approved now in the United States to up to 100 grams. KTP, HOLEP, PURP, whatever you actually like. There's HOLEP for bigger prostates and open surgery or robotic surgery. There's another circle that should be included here, and that's called Aqua Ablation, which we'll talk about in a few moments. Now, if you look at the MRIs, the vast majority of patients have prostate sizes approximately 25 to 75 milligrams. So, grams, excuse me. So approximately 75% of men are in this range. And those are the majority of patients that actually we see. The less and less patients we're seeing with prostates more than 100 grams. So the minimally invasive options become very, very good, very, very good, because that represents the majority of patients who we're actually going to see. Now, I don't know if you're doing prostate arterial embolization in Morocco, but I thought at least we should talk about it. It's where basically beads are placed into the prostatic artery, and that creates changes in the blood flow, and therefore the prostate can shrink. And there's been a host of literature out there. This slide comes from my good friend Klaus Rareborn, who gave a very nice review. This comes from a review from Zumstein, which I also reviewed in the Journal of Urology, and that represents the experience with PAE. Now, this was a very interesting study that I commented on in the Journal of Urology, which created a lot of irritation among some of my colleagues, because this was a single-blind, sham-controlled superiority trial. So can you imagine you actually doing a sham trial? And the problem with this data, as I'll show you in a couple of minutes, is The sham group got catheterized one prostate artery, but no particles were injected. We could never do a trial like this in the United States. And I'm not sure you could do it in Morocco either, but certainly in the United States, it would be very hard to do the sham group because you get a lot of radiation exposure. So if you look at the PAE group, they had outstanding results, at least in the literature. The symptoms go down approximately 15 points and stay stable. And in the sham group, it also goes down. But here's the problem with the data. The data almost looks a little too good. It's almost everything is straight lines and overlap, straight lines, straight lines, straight lines. And this data we actually don't see with any other type of procedure. Now, the other thing I will point out, which is very, very interesting, is that PSA goes down about 50%, 50, which is what we see with a 5-alpha reductase inhibitor, like finasteride and dutasteride. And yet, the amount of improvement we see, at least in the literature, seems to be disproportionately high in patients who are on this procedure. The data actually doesn't make a lot of sense. So why does the PSA go down by less than 50%, and yet the symptoms and improvement is much higher than a 5-RI? Makes no sense. So you wonder, because the data does not seem to fit historical data with other types of therapy. The tuna device. The tuna has been around for many years. It uses heat to melt the prostate. The needles are placed into the prostate, creating a coagulation necrosis, and it works. Certainly in responders, this is the 3-year data, and there's clearly improvement. There's also improvement in flow rate. The problem is that when you look at long-term data, it does not seem to work very, very well. And therefore, in the AUA guidelines, we no longer recommend tuna as a therapy. This is using microwave therapy, and there is a coagulation necrosis as seen on MRI. We know that that's what it causes. But if you look again, long-term data, that was the problem. And microwave used to be a very, very popular procedure in the United States in the late 90s and the early 2000s. But because of changes in the data and reimbursement, that evolved. And this is not really used much in the United States. And you can see here the improvement in symptom scores. And it was less than a TERP. It was less than a TERP, but it was not sustainable. And that was really the issue that was of concern. So now let's talk about the minimally invasive therapies that are out there. There is the prostatic urethral lift. And again, I'm not sure if you have it in Morocco, but it uses a stapling device. The stapling device actually opens up the channel. So it's done anteriorly with this device. Some clips are placed. It's very easy to do. And about 4 to 5 clips or staples are placed. It opens the channel, and you can see here prior to the therapy and after the therapy. And you can see an open anterior lobe right into the prostate. And of note, this is obviously not a very large prostate. A lot of data, a lot of information, lots of studies. It works in patients who actually continue therapy. This is the 5-year data that was published about a year ago. It had a sustained improvement in symptoms and flow and quality of life. Now, one of the things I always want to remind my colleagues here from Morocco is that when you read these studies, remember, it's only the responders. So those people who didn't respond, they had their TERPs, or they had other procedures, or they left the study, are not included in the analysis. We only see the best of the best, unlike a medical therapy where everybody's data is incorporated. The retreatment rate was 2 to 3% per year over 5 years. So the retreatment rate's about 15%, 15 or so percent at the end of 5 years. So in those patients who it works on, there seemed to be a very good response. The most common side effects were dysuria and hematuria. And approximately 10% of my patients require a catheter overnight because of their hematuria. Urgency, less so. Urgent continence, very, very uncommon. No incidence of ejaculatory dysfunction. One of the questions that I get asked is, well, if I do this and it's metal, can I have an MRI? The answer is yes, because they're titanium and they don't really move and it's safe. The question is, well, if I have it there, will I be able to diagnose prostate cancer? Well, certainly in patients with transition zone, with peripheral zone cancers or posterior cancers, it's not a problem. There are programs now to try to read the shadowing within 10 to 15 millimeters of the implant. And that continues to be something that we're actually looking at. So if you were doing this in a patient with a low probability of cancer, if he has a suspicious PSA elevation, a negative biopsy, and no suspicious areas, you may want to do a fusion biopsy in the anterior zone. But again, this happens very, very rarely. Now, this is the resume, which is convective heat, as opposed to the tuna, which is conductive heat. So this is convection. Convection is right here. And what happens is when the steam is injected, you can see that the vapor goes throughout the prostate. It doesn't stay in one place. So therefore, you can get a quicker effect. So the tuna device, which was about 1 minute and 20 seconds of treatment, here it's about 9 seconds. The tuna device uses conduction, so it's much slower, which requires, therefore, a longer heating as the heat is transferred from cell to cell. So it's inconsistently treated, which is one of the reasons why tuna may not have had a good effect. And this is what the device looks like. You can see steam being injected into the prostate, and it creates a coagulation necrosis. Each treatment is about 9 seconds. And we usually do anywhere from 4 to 6 treatments. And if there's a middle lobe, we will actually wind up treating the middle lobe. Very easy to do. It's even easier than tuna, and it certainly takes less time. So you can see that being parlayed right there. And you'll see one more treatment in just a couple of minutes. And you get a nice coagulation necrosis within the prostate. Okay. So again, this is what it looks like. And this is a before picture, and this is an after picture. And this patient had their middle lobe treated, and you can see it appears to be gone after 6 months. So again, a very nice response. This is the improvement in symptoms, and this is the improvement in flow rate, and this is durable. So this, remember what I said about medication. Medication with even combination is about 6 to 7 points. This is about 11 points. Surgery is going to be about 19 or 20 points. So this is a middle of the road approach. And you can see the improvement flow rate is about 4 milliliters per second. Medication is going to be about 1 to 2. Minimally invasive therapy is about 4 to 5, and surgery about 10. So it's as you look at all these therapies, it's kind of in the middle between medication and surgical therapy. This is quality of life improvement and the Bph impact index. So the data looks pretty nice. Now, sexual function, there is no effect on erections. There is no effect on ejaculations, regardless of the measures that we use. So the rates are very, very low. So at least in the 4-year data, it seems to be a very nice therapy. And I do Urolift and resumes in my office. For patients with a large middle lobe, I use the resume. And for patients who just have bilobar hypertrophy, I use the Urolift. Now, one of the nice areas is the middle lobe, and that's why I like this procedure. And you can see in patients who did have a middle lobe, the improvement is actually quite good. This is where the lateral lobes and the middle lobes are treated, and this is where the middle lobe is not treated. And you can see that when you treat the middle lobe, the improvement in symptoms and flow rate is much higher. So it's kind of good, and we kind of like that procedures. So now the question is, okay, which one do we use? What is the best type of therapy? So this is a very nice summary review of stuff that's out there. And this is a slide that you should remember. Essentially, this is the improvement, if you look at various studies, in IPSS at a year. So remember I said a TURP is about 14 or 15 points. Resume and Urolift will be about 10 points. And medication is going to be at 6 points. So it's a nice halfway procedure. Improvement in flow rate. With medical therapy, it's about 1 to 2 mils per second. With a TURP, it's going to be, or PVP will be about 11 to 12 milliliters per second. And with the Urolift and with all these others, it's about 4 to 6 milliliters per second. The surgical retreatment rate with a TURP is about 15%. it's about 13% for the UroLift. Resume, it's about 4.5%, and this is the PVP as well. But the big issues, of course, are sexual dysfunction, which are higher in the TURP and the PVP group, and much less, obviously, stricture and stress urinary incontinence. So, as I said before, what makes a successful minimally invasive therapy? It's tolerated, it's quick, short recovery time, and patients can go back to work. Now, how should we look at some of these things? And there's something, and I wrote an article for Urology Times that actually tries to define what we consider to be a successful minimally invasive therapy. And that is one that's not associated with surgery, with harms of surgery, particularly sexual dysfunction, and can be delivered in the office. So there's a difference between efficacy, excuse me, and effectiveness. Efficacy are the clinical trials. But this is let me go back a second. But effectiveness is the real world. And again, this is an article that I wrote. And we look at what we have, the data in our world with patients, not in a controlled trial. And I think that's where it's important to look at. So if we look at comparing the UroLift and the Resume, I'm sorry again, the computer seems to be jumping a bit. The symptom score is about similar. And if you look at the real world, it matches up pretty nicely. Essentially, what we see in clinical trials, we actually see in the real world. So from a quality of life, the same thing. This is the retreatment rate. We don't really have that in real world data. It can be done under topical anesthesia. The rates of stricture are a little bit higher with Resume, not surprisingly, and the rates of infections are much higher with Resume, and that's one of the issues that are being looked at. Catheterization, almost everybody with the Resume goes home with a catheter. About a third of patients go home with the catheter here. In terms of post-op retention, high with the Resume because it's a heat therapy, but otherwise pretty similar. So in my world, and I've written this, if I were the patient, I would want to have a UroLift first, unless I had a big middle lobe, and then I would want to have a Resume. Now, if you look at the patient experience, if you compare the patient experience with the UroLift and the Resume, data is very interesting. This was just published in the Canadian Journal of Urology, where it compared for the first month UroLift versus Resume. It's very similar. In fact, the Resume had bigger prostates, and the baseline IPSS was pretty similar. But if you look at the improvement in the first month, it's higher for the UroLift than for the Resume. So in other words, patients heal a lot faster than with the UroLift and with the Resume, and their sexual function comes back faster, and they use less medications after the UroLift and the Resume. So that's why I like the UroLift, because you heal faster from this. Finally, if you want to compare it to medical therapy, which is what we talked about, this represents comparing the prostatic urethral lift versus MTOPS, the sexual function. And again, it's a busy slide, but the bottom line is that men who had a UroLift tended to have better sexual function than men who had combination therapy with either doxazosin and finasteride in the MTOPS trial. So sexual function was better with the lift than using combination therapy, which makes sense. If you look at erectile function for the lift, it's much better than what we see with medical therapy. Ejaculation, of course, is going to be better because you do get ejaculatory dysfunction issues, particularly with the combination of finasteride and doxazosin. So that's why we like the minimally invasive therapies. So what's the bottom line? The bottom line is that office-based procedures are good for patients. They're good for urologists. Sexual function is a big selling point. The long-term data in those who respond is more than those who do not. We don't have data on that, and that's part of the problem. But the bottom line is it's driven by economics. So in the United States, if we do a TURP and using government insurance, which is called Medicare, the reimbursement in Manhattan, which is the highest in the country, is about $800 US. If I do a UroLift in my office and I put in 4 implants, the reimbursement is $2,000. So it's easier to do and it reimburses more, which is why so many of them are being done. And whether we like it or not, or agree with it or not, there's science, but there's also money And this will obviously change as well. So the last 5 minutes of my talk, I just want to talk to you about Aqua Ablation, which is a nice new procedure. It's a robotic TURP. It has a ultrasound, a robot with a handpiece that's placed, and then it is pre-planned. And instead of using heat, it uses high-speed water. I think we have a slide of that. So essentially, you can adjust how much the water is going into the prostate, depending on how much power you're actually using. So let me just let this roll for a couple of minutes. So basically, the prostate is measured, and then there's pre-planning. So essentially, here is the treatment area that we want, and this is the prostate at its maximum space, and you can adjust this. It's what we're doing here. And you want to make sure that you're within the capsule, and you can adjust the 4 treatment points, as you can see here. So you can see that we're adjusting the sides of this in the transverse position. And this is the actual treatment that's occurring. We're now placing our markers. This is our treatment zone. This is the sagittal, and we do an ejaculation preserving, what we call a butterfly cut, as you'll see in a couple of minutes. So I'm planning this out. You can see that I go posteriorly, and I can adjust, how deep, how far, how much. So this is the planning stage. You can see how we're adjusting this and getting ready to go. Let me go to the next slide. And then we treat. So I'll let this run for a couple of seconds. You can see we're ready to go, and you can see the power wash. You can see the prostate actually being eliminated. It's amazing how fast. And this treatment is going on just for it's a 2-minute treatment. And we're eliminating huge amount of prostate tissue. You can see that this prostate tissue is now, which used to be up here, is now down here, because that's how much has been eliminated. It's amazing. And what happens is that when it gets closer to the verumontanum, you can see that it uses a different angle. Because instead of going down here towards the veru is here, we actually cut only to here. So you can see that it's following the pattern. It doesn't cut here, because we've set the pattern, the limits, the border right here. And then it does the other side. So it's called a butterfly cut, because it looks like a butterfly. You cut just to the sides. And I think we have another slide of this. And this is, you can see on ultrasound what's going on. You can see on the inside what's going on. So I'll let that play for a moment or two. So essentially, I'm not, this is being done automatically by the robot. It's set. You can see the water splashing back and forth. So once again, you see how it comes, the veru cut. It only cuts to the side, it leaves the tissue here. Because it's only cutting right here, it's not cutting all the way down there, which is why and you can see right here how much it's left. It's very, very, very nice procedure. And again, it's new, we've been doing them for particularly larger prostates. Before, after. And this is a comparison to TURP. And this was the side effects are less with this than with TURP, which is not terribly surprising because it's ejaculatory function. Ejaculatory function can be preserved with the Aqua Ablation versus what we see with the TURP. This is the improvement in symptoms. It's TURP-like. It was non-inferior in these trials. The flow, again, similar to what we see with the TURP. And in more than 50 groups, and more than 50 grams, it seemed to be more effective. Less to do, so I tend to do this in very, very large prostates. I'm very comfortable doing a TURP to about 120 grams. Now I'm doing the Aqua Ablation in more than 120 grams. It's a very, very nice procedure. Now, there are other procedures as well. There's HoLEP, there's open prostatectomy, and I'm certainly not saying it's better. It's just another nice way of managing. Procedure time, much less. I can do 150-gram prostate in about 20 minutes between setting up everything and doing the procedure. That's what I like a lot, because you can really save a big difference. So in my last slide, last couple of slides, excuse me, all procedures do well. You know, I would never argue that one is better than the other. I think it depends what you like to do, and you do them. Somebody who does a lot of whole enucleation, I'm sure is very good at it. It's not worse or better than a bipolar vaporization or any other procedure. It's like what you're comfortable doing. It's a great place for us to meet. And I hope you'll consider joining. The date has just recently been changed. It was supposed to be in September, but our AUA, which will be live together, not by Zoom or not by virtual, will be live. I hope you come to see us in Las Vegas, and hopefully you will have a wonderful time. So again, thank you so much to the Moroccan Urology Association, to the American Urological Association for inviting me here and being part of this wonderful program. And I hope we can continue to collaborate, because in my perspective, I had the opportunity to speak around the world. I always learn more from everybody, and I love to learn how other people around the world are doing it. And I hope you enjoyed this presentation. Thank you so much.
Thank you, Professor Kaplan, for this excellent presentation. And now we can move to a survey which evaluated the trends of Moroccan urologists. What do they think about novel techniques of BPH? So, Dr. KHDACH, you can go on, please.
Okay. So, good evening, everyone. First of all, I would like to thank Professor ELMCHERQUI, Professor BELAHNECH, and Professor ZIOUZIOU for allowing me to participate to such an interesting gathering. Also, I would like to thank and congratulate our speaker, Professor Kaplan, for the time and energy that he gave to the group, and of course, AstraZeneca's team for their efforts. To start with, allow me to introduce you a survey around benign prostatic hyperplasia and new technology. The questions are the following. The first one, about 80% of the answers confirmed to operate more than 50 BPH per year. The majority of the answers confirms to work for the private sector. Third question, which is about the seniority in the field, about 31% is practicing for now more than 20 years. About the half has been practicing between 10 and 20 years, and about 15% for less than 10 years. The surgical treatments judged to be the most commonly used are the monopolar resection, followed by transvesical adenomectomy and bipolar resection. In the 5 coming years, in terms of BPH treatments, the vast majority says to be willing to search for new technologies. Also, the majority says to rather invest in techniques such as bipolar endoscopic enucleation, HoLEP, and Aqua Ablation. An interesting outcome of about the total participants saying not to use any of laser or thermotherapy due to the fact that none of them are currently available. For patients who are unfit for surgery, about 36% confirm using permanent urethral prosthesis, and about the 42% say not to use any because of its high cost and or unavailability. Opinions about embolization of prostatic arteries taking the place of prostatic resection diverge between about 47% saying no and about the other half arguing yes. The majority believes that treatment by Resume will not take the place of the resection for prostate less than 80 grams. The same for Resume, not taking the place of the medical treatment. Talking about Aqua Ablation, the vast majority believes that the technique doesn't have enough background. 76% believe that the prostatic injection of Botox is ineffective, and about 64% said that it is not recommended by the EAU, and 41% said that it presents many side effects. An interesting 61% believe that Urolift is a rapid technique, and only 33% believe that it can take the place of the prostate resection. The majority thinks that the use of sterile water in prostate resection costs less than glycocol, and about the half majority refers to the high rate of TRIP syndrome, and 39% said that there is not a big difference between saline irrigation and sterile water in terms of complications. In case of glycocol out of stock, about 57% will use monopolar resection with sterile water and bipolar resection. About 47% believe that there is not a big difference between resection using hot or cold saline seroma, and 35% said that it allows a better vision during surgery and less gas bubble. Finally, the vast majority believes that it makes no significant difference in adding tranexamic acid during resection of prostate. Thank you, and I will let Professor ZIOUZIOU continue the discussion.
Okay, so let's move to the questions. Professor Belahneche, do you have a question to Professor Belahneche? Do you have any question? Okay, so I have...
Yes, I have a question.
Okay.
So first of all, I would like to congratulate Professor Kaplan for his presentation. Really, it was very, very interesting and exhaustive. And I am proud of you, Imad, and the qui vient après toi. Really very good presentation. I would like to say that now BPH and new technology is becoming something really more difficult than it used to be in the past, because now you have a lot of choice. And as I can see, we can plan two technologies at the same time for the one patient, for example. As I can see, we can use Urolift, for example, for lateral lobe, and use Resume for the median lobe, for example. So I am asking Professor Kaplan, what do you think will be the trend for this new technology? Are we going to stick to one technology at the end, or are they going to be more numerous than they are now? That's my question.
First of all, thank you for your kind comments. Thank you very much. Merci beaucoup. And there's a lot more coming. BPH is a very big business in the United States, and I think throughout the world.
As I can see, yes.
And there is other therapies coming, and I don't think there'll be one. It's like, you know, when you go to a restaurant, you don't want just one meal. You want to have a lot of different choices. So it's the same idea. I mean, look how many treatments there are for other conditions. So there'll be a lot of room. But I will say that it will have to do a lot with the money as opposed to the science. You know, what's available, what can be afforded. But and again, I always, you know, they always want me to check these technologies. I do all of them. Do I think one's better than the other? Not necessarily. I think what we try to do is match up the right therapy for the right person. That's what we try to do.
For joking, there is some restaurant with just one menu.
Well, if they do well, then that's great. But it's hard sometimes.
That's for joking. Vas-y, Imad.
Okay, so Professor Kaplan, do you think HOLEP may be really considered as the gold standard of BPH treatment?
Well, I don't think there's a gold standard. I think there are a lot of standards. People always want to say one is the best. If Holium was the best, at least in the United States, not many are being done. So why aren't we doing the gold standard in the United States? Other parts of the world do a lot of HOLEP. So I think that the gold is tarnished. I don't know how it translates into French. It's a little scratched, the gold standard, whether it's TERP or HOLEP. I think if somebody does a lot of something, it's their gold standard. So if it works for them, it can be their gold standard, not necessarily mine. But I think HOLEP's a great procedure, bipolar is a great procedure. It's what you do a lot of and what you're comfortable, and that's fine.
Okay.
I would like to have a question about the physiopathology of the bladder alteration. When there is an obstacle on the way of the outlet of the bladder, the muscle will undergo a lot of change, gene change, and do you think that this change begin before symptom begin? Are there formal the symptom? Because it's very important. Patients come to your cabinet when they are suffering from something. Are we now heading for screening obstacles which are not symptomatic? Because this kind of change will become, let's say, would not heal after this obstruction if they stay a lot of time.
Right. So that's a good question. These pathophysiologic changes occur throughout the cycle. In some people, they can have early symptoms, and in some people, they have no symptoms. So it's different for different people. And the way this works is there's collagen that's deposited in the extracellular matrix, and that causes changes in the function of the bladder itself. We've seen patients with trabeculated bladders, large prostates, and they don't have any symptoms. And then we see the opposite, patients with small prostates who may not have much changes in their bladder with a lot of symptoms. So it's not a one-to-one ratio. I think sometimes you see it and sometimes you don't. It changes.
And we can have this change even in patient having no obstruction, just because it's an elderly condition.
Yes.
Coming with age.
Yes. And you know what? Women have it too. You know, maybe not as much, but if you look sometimes in a woman who has different type of symptoms in their 60s and 70s, they have trabeculation. Not as much as a man, but they also have trabeculation. They don't have a prostate. So there's other changes, aging, vascular changes, neurologic changes, all of that's possible.
Thank you.
Okay, we have a comment by Professor Marzouk who say, an old surgical citation says, whenever you have lots of surgical techniques for a given condition, that means none of them is really efficient. Any comments? Do you agree with that?
Well, I don't disagree, but it gets back to the original comment that we need to do a better job of matching up the therapy to the patient. There's no one gold standard because what works for one may not work for another. So there are different reasons why patients have symptoms. I think we have to remember that. So there's something called precision medicine. Well, we can do more precision. There are patients who do well with a resume. There are patients who do better with a HOLA. There are patients who do better with medications. There are patients who do better with physical therapy. So I think our challenge and our goal is to try to match the right therapy for the right patient. So I would not say that it's inefficient. We are inefficient because we're not doing a good job of matching the right therapy to the right patient. So the more we have, the more opportunities we have to make a good match.
Okay, so what do you think about intraprostatic injections?
Well, they haven't really worked very well. Botox, ethanol haven't worked well. There's other technologies that are being looked at, but they haven't come to at least approval yet. So I would say at this point, there's not a lot of data to support it. Just to answer something else as well, stents. Remember, we used prostatic stents many years ago. That's coming back. There are at least 7 companies looking at stents. Balloon dilation. I just wrote an article for Urology Times and presented at the American Urologic Association, is using balloons to dilate and then using something called paclitaxel, which is a relative to Taxotere, and that creates a reduction in the inflammation. And the data has been terrific, and we're doing a large trial. So things are coming back, stents, balloons. So sometimes it's called reinventing the wheel. You know, we're coming back to some of the old stuff. It's like clothes. Things that you wore 20 or 30 years ago are now in fashion. So maybe don't throw out your clothes. You can use them again.
Okay. I have a question about catheterization, because when we read an article, a scientific article, we see that catheterization patient go home with catheter, but how many days we stay with catheter? For example, if we take in account a resume technique, for example, did they remove the catheter the day after, or they have to keep it 1 week or more if there is a problem? How do you manage this post-operative? Because when you say, oh, it's an outcome patient, it's being done on an outcome patient basis, it doesn't mean that the problem is solved. The problem would be just transported sometimes at home, and a nurse or probably the urologist himself has to go and treat the problem, which is urinary retention after operation.
Yeah, I mean, that's so part of when we talk to this, we tell patients. So at least in my world, it's easy to take it in and out. And it depends. So with Resume, it's about 3 or 4 days. The Urolift, it's about 1 or 2 days if they stays in. But you're right. It's not, but then again, for TURP, it's also, 3 or 4 days. So, and even HOLEP, the gold standard, you go home with a catheter. So I don't think we can get away. The Urolift, only about a third of patients have a catheter. So it's less of it, but any patients at risk. Some patients after a cystoscopy need a catheter.
Yes.
So yeah, that's when you manipulate the urethra, there's always a risk for that, no matter what.
But I would like to know how many days in general did they keep the catheter? They keep it in 1/3 of the patient, but how many days did you keep it? 1, 2 days?
With Urolift, it's 1 or 2. With Resume, it's 2 or 3.
2 or 3 days. Okay.
In general, I mean, for the most part. There's exceptions, but for the most part, yes.
Okay, another question. Which technique do you prefer for treating BPH plus bladder calculi?
So those patients I have to do in the hospital. I can't do a laser or a lithotripsy in the office. So if I were going to do both, I would probably do, what I do is a bipolar vaporization, a bipolar TURP, and a laser lithotripsy of bladder stones. But if somebody wants to use a laser, that's fine. If somebody wants the Aqua Ablation, it's hard because it's 2 different instruments. So it's hard to do Aqua Ablation with stones. So I do a bipolar vaporization and stones. If the prostate, we had a patient recently who had a prostate of 200 grams and 30 stones. That's hard to do transurethrally. So that patient wound up having a robotic prostatectomy and stones removed. He was also obese, so that worked well.
Okay, so
Amen.
What do you think also about laparoscopy?
It's fine. For those who do it, it's fine. I don't do it. I don't do that procedure, but I think that's a lot of work, and I'd rather do a holmium enucleation or a aqua ablation than putting a patient under general anesthesia and having an abdominal approach. Is it wrong? No, it's fine. But I prefer to do things through the penis if I can, through the urethra, because you don't have to open up the bladder.
Okay.
Amen.
Okay.
I have a question. Yes. Dr. Kaplan, what is the future for monopolar or bipolar resection?
Well, I think it depends where in the world. Yeah, it depends where in the world you are. I think bipolar is here to stay. I think in the United States, many more bipolar is being done than monopolar. In certain parts of the world where they don't have the financial resources to buy those, the equipment, monopolar is okay. I like bipolar more than monopolar, but I think in the hands of experienced surgeons, monopolar is fine. But at least in the United States, the trend is bipolar as opposed to monopolar. In Morocco, I forgot the survey. Is it more mono or bipolar? Or people don't think it makes a difference? Which is done more in Morocco?
Monopolar.
Monopolar. Yeah, well.
Monopolar. But we have just switched to bipolar. Many urologists are now switching to bipolar because we have no more glycocol for doing our resection with monopolar. But as you can see on the survey, many use sterile water.
Right.
Are you agreeing with that? We agree that we can use sterile water.
Well,
is there a danger in your experience if never you have this experience?
Yeah, no, I did. I've been around a couple years. Even though my hair is not gray yet, but soon will be very, very gray. I would obviously want to stay away from water and monopolar if we can. So that's why I like bipolar, because there's no TOR syndrome and it takes away the whole problem. I would rather you do a bipolar than a monopolar with sterile water, unless you don't have a choice, but in terms of preference.
I would like to know, how do you manage the patient who have urinary retention? Do you treat them as rapidly as possible, or do you make just a catheter and wait for a time to see if they can have a spontaneous mixture after a while? Or
Right. So we will give them a trial of an alpha blocker. We'll try, and about a third of them may be successful. But I find that ultimately a lot of them are going to wind up with surgery. So I don't rush it, particularly if they have an infection. So, I can give them 2 or 3 weeks. Some patients want something done right away, and, we tend to go to surgery more. But I will give them, I always offer them the trial. I'd rather see medical therapy and then do it electively. Because if patients go into retention, obviously the prostate has more edema and it can bleed more. So I'd rather do it electively if I can. Sometimes, many times you don't have a choice. So you got to do what you do.
Ahmed?
Okay.
Can question, Ahmed? Dr. Kaplan, maybe Aqua Ablation procedure, it's very interesting. How much procedure cost in USA?
The procedure. Well, it's a good question because it just got approval to get paid for in the United States in November. So I don't know what they're charging for the machine because they're obviously want to get it around. The handpiece is $2,500, $2,500. There's the disposable. But the United States, the hospital gets reimbursed $9,000. So for the hospital, it's like, okay, good profit. For the urologist, they make a little bit more than a TURP. So the world is not about the doctors. The world is about the hospitals, at least in the United States. So it's a good deal for the hospitals. For the urologist, it's nothing special. But it's a nice procedure for large prostates, and which is where I like it. I like it very much for large prostates. And that's, again, to be clear, I'm not saying it's better than Holmium. I'm not saying it's better. It's another option. The reason I prefer it is because you don't have to open up the bladder. for the most part.
Okay.
Okay.
What are the novel techniques you can use for all the prostates, independently from prostate size or conformation?
I'm sorry, I didn't get the first part of that.
Okay, so what are the novel techniques we can use for all the prostates, independently from the prostate size and conformation?
Sure.
So, yeah.
Yeah.
Okay.
You know,
When
depends how good.
when you're speaking about the shape of the prostate, are you saying that prostate with two lobes and prostate with two lobes, or there is something more special about the shape we have to know?
No, it's the intravesical. It's the middle lobe.
Yes, the medial lobe and the yes.
So we published a survey last year, our 12-year experience with just taking the middle lobe out itself, leaving the lateral lobes, and it was a very good experience. So when I say TURP, by the way, to me, a HOLEP is a TURP, and a TURP it's just a different instrument. So I mean a transurethral approach. So it's not necessarily electrical versus laser. It's interesting when people say to me, well, you know, somebody said they have a HOLEP. I said, you mean a TUR nucleation? You know, it's all the same. It's basically it's marketing. Green light to me is a TURP with a laser, and that's fine. But you know, we try to make this into this whole different, you know, vertical. But at the end of the day, it's a transurethral approach. So whatever you like, you know.
Don't worry, because in Morocco, many people are speaking about monopolar resection like laser. They say, are you going to make me laser? We say, yes, you are going to have laser.
Right. You're going to have an electrical laser.
Yeah.
Exactly. It's okay. It's similar in the United States. You know, it's what people are used to. That's all, and that's fine. It's fine.
What are you doing when? Do you see many bladder stones with BPH? No.
Yeah.
Are you
with middle lobes?
middle
They
lobes?
always have a middle lobe. Yes, not always, but almost always.
And you are managing them with the laser?
Yes, I mean we used to do electrohydraulic lithotripsy, which I loved, but that they're not doing it in the United States. So it's usually a laser, a holmium laser. It works very nicely.
But you are not doing them in your office,
No,
are you?
No.
Need more
equipment and more anesthetic. So we do them in the hospital.
Okay.
Excuse me, I have a question. Professor, what about the combination of two techniques? For example, are we allowed to use in the beginning a resume, and after 3 months or maybe 1 year, if it doesn't work, can we switch to a Eurolift technique?
You can. I mean, you know, it's America. I mean, Morocco, I guess you can, if you had that technology. In general, I've not done that, because in my mind, if they fail one minimally invasive, I usually don't go to the other. But that's not because it can't be done. You can. It's just in general, it's not, you know, it's not done. But sure, why not?
But it's not gonna be difficult to do second technique in the same time. No,
I don't think so.
Okay.
Yeah, particularly if you do a resume first, because if you do a resume and then you put the implants in, it's fine. We've not really done a resume with implants because I don't know what the effect of the heat and the steam is, but I've done TURs on patients who've had Urolift and didn't work. So you need to have a very thick band because you need a thicker band, a thicker loop to cut the Urolift. That's the only difference.
Okay.
Is there some limitation to make Urolift? For example, is there, for example, infection or difficulty to have a clear plane between transitional zone and peripheral zone when you are doing your
No,
rectal sonography, for example?
No, it doesn't.
No.
No, not really. I think that you don't want an infection, obviously, but no. The reason if the patient has a middle lobe, I don't do a urolift, because why would it help? If I'm opening it up anteriorly and I still have this middle lobe sitting up, it's not going to help. So we don't do that.
Okay. In your opinion, which technique would be the most cost effective?
For who? The doctor or the patient?
For both.
Well, in the United States, the most cost effective for the doctor is urolift today.
Yeah.
In terms of the patient, if it's covered by insurance, it's covered by insurance. If they have to pay out of pocket, it costs more to have a urolift. So let's go back a second. So for the urolift, when I do 4 implants, we make about $2,000. Each implant costs about $1,000. So I have to pay about $4,000 to make $2,000. So it's about a $2,000 profit. So we get, let me say that differently, I'm sorry. So we get reimbursed $6,000 to do 4 implants. $6,000 US. And it costs, the cost of goods is $4,000. So we make a net profit of $2,000. It's a crazy system. It's a crazy system. Can you imagine to put in 4 little implants? The cost of goods is $6,000 US. You can go to a lot of restaurants with 1 menu and enjoy the meals. That's, you know, it's driven a lot by economics. There's no question about it.
Yes.
Okay, do you have other questions, Professor Belahneche?
You know, it's when we see the numerous technique they have in the United States and the, let's say, the war between these technologies, because it's a war, an economic war, but it's a war. We can really, it's amazing. It's amazing because we know that a lot of money is going on in this field, which is a benign condition. And I am comparing your case with ours. With ours, prostate are bigger, for example. People are coming later with the post-micturition residue, which is over than 100 cc, you know, a lot of infection, you know, a lot of lithiasis, bladder lithiasis. So we can see a patient like yours in the towns, modern towns like Casablanca, Rabat, Meknes, as you said last time. But you know, there is a lot of patients coming from the countryside with very, very big prostate, and with the catheterization, they are coming with catheter. Also, you have to solve all this problem with a lot less costs as possible, you know. And it's not the same situation, even for urologists working in the private sector, which is a sector in which the patient have to pay their treatment. They have to do their treatment at lower cost as possible, so that the patient can pay. So we have not the same condition, but at the same time we are looking for a technique which probably comes and help us to treat this patient with a stay in the hospital as short as possible, which is very important for our economy, for example.
Right.
But it's just a commentary. It's not a question. It's not a comment. So I am amazed about all this technique, and with the offering for the patient to choose between, yes, with the urologist directing him for this choice or the other, but there is a choice, a real choice, a panorama of choice. But here in our country, the choice is very limited until now. That's the comment I have to say.
I agree.
Okay.
Thank you.
Imad, take-home message.
Okay, so let's move to the final part. I'll share the screen. So for the take-home message, during the last years, the strategic landscape of BPH treatments have changed significantly. Some of the techniques are experimental, like tuna and microwave therapy. Other techniques are well established and very promising, like Urolift, steam therapy, and Aqua Ablation. So the urologists are the winners from all of these techniques. We have more choices to adapt the treatment for each patient. Also, we should take into account, of course, the cost effectiveness of each technique. So thank you very much, Professor Kaplan, and for this excellent presentation, and all the participants for the nice discussion we have. And now Dr. ELMCHERQUI, you can conclude.
Thank you. Thanks, Dr. ZIOUZIOU. Finally, Dr. Kaplan, a big thanks for this presentation, excellent presentation about BPH and new technology. Thanks, Professor BELAHNECH, Dr. ZIOUZIOU, Dr. KHDACH. Thanks for AstraZeneca. Sabrati, Aziz. Maybe I will see you, Dr. Kaplan, in Las Vegas 2021. We will program a Maghreban urological session. Maybe if I can invite you in this session and to participate with us, it's very interesting for us. I give you an appointment for another webinar. Good night. Thank you. Thank you.
Thank you very much, and it will be a pleasure. And I hope to see you in Las Vegas. Maybe not in the casino. We'll see you in the conference, and
yes.
That'll be our pleasure. I also want to thank the AUA and Lori. She's on as well for organizing this, and I really appreciate all the questions and your participation. To make a good conference requires, interest, and I was terrifically impressed with your questions. So thank you, and have a wonderful night.
Good night, Lori.
Bye-bye.
Bye-bye.